Good afternoon. Good evening. Good evening, everyone, and welcome in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings, weekly online meetings in our same time, Wednesday, 9:30 p.m. Today we have our great speaker from South Africa, Professor Mignon McCulloch from South Africa. And we are welcoming, all of us welcoming here today in our platform to give us a very nice lecture, expected lecture about peritoneal dialysis in pediatrics. I will leave the floor after this introduction for Professor Fatina Fadel to introduce Professor Mignon. But I would like to congratulate her for her award that received in ISPD Congress last month. Which was a very successful Congress, and Professor Mignon received award during this Congress. Our moderator today, I would like to welcome her, Professor Fatina Fadel, Emeritus Professor of Nephrology and Pediatric Nephrology in Cairo University, Egypt. She is the head of Interventional Nephrology chapter, also in Egyptian Society of Nephrology and Transplantation, and one of our Egyptian eminent pediatric nephrologists and pediatricians in general. I would like, before leaving the floor, to thank our coordinator today, Dr. Hazem Abujusha, and leave the floor to Professor Fatina to introduce further Professor Mignon, who is the current full professor and chair of Nephrology Department and Transplantation in Cape Town University, South Africa, and the current president of South African Society of Transplantation. So please, Professor Fatina, take the floor and further introduce Professor Mignon, and I will come back after the lecture for the discussion.
Thank you very much, Professor Yasser, for this kind introduction and for choosing, of course, Professor Mignon to be with us today. Good evening, everyone. Actually, it's my pleasure to introduce a dear colleague in the field of pediatric nephrology, Professor Mignon McCulloch, a very kind, helpful, and supportive person. She is full professor and head of clinical unit of pediatric nephrology and solid organ transplantation at Red Cross War Memorial Children's Hospital, and she's senior lecturer at the University of Cape Town. She is current president of the South African Transplant Society, and she was the past president of EPTA, International Pediatric Transplantation Association. Her interests include also pediatric nephrology and care of critically ill children, especially with AKI, requiring all forms of renal replacement, including dialysis and transplantation in infants and children. She is on the Saving Young Lives Steering Committee, and she enjoys training fellows and outreach work in Africa, developing pediatric renal and transplant programs. She will be hosting the EPNA Congress in Cape Town, February 2025. She will give us a talk about acute peritoneal dialysis in pediatrics. And I know during her talk, she will give us some innovative ideas about the acute PD catheters and the settings for PD in small infants and even in newborns. I'm sure that you will all enjoy her talk. Please, Professor Mignon, we are waiting for you.
Assalamu alaikum. Thank you very much, everybody. Thank you, Fatina and Yasser, for your kind introduction. I'm really delighted to be speaking at your meeting. I've been to Egypt a number of times, and it really is a beautiful country with beautiful people. I'm also very impressed that there's so many people on this call at this time of night. I think your commitment to nephrology is amazing. So I gave a similar talk 2 weeks ago where I met Fatina at the ISPD Congress, and I spoke about PD for AKI. And if you're an adult nephrologist, I've made this also relevant for adults. And so I'm going to be speaking on PD for AKI around the world. I was very privileged to be asked to give the Carl Nolf lecture at the ISPD, and so I've just given you a similar version of that. So if you are sitting in the audience and you think you don't really need to worry too much about PD and that your dialysis unit looks like the one I'm showing you, the question I'm going to ask you is, will this work in a crisis situation? And so we know that the influence of climate change on extreme environmental events has really been a problem. And last year, 2023, a year of climate extremes with devastating storms and rainfall, heat waves, and droughts more severe than ever before. And if you look at this year, they've already said the 10 extreme climate events of 2023 were as listed there, and you can see almost every month there's been some kind of flood, snow, cyclone, sandstorm, heat wave, and the list just continues. And historically, we know that there was even right in the beginning in the year 526, there was an earthquake in Antioch. Haiti then had a very big earthquake, and then we know in Syria and Turkey in 2023, there were quite big earthquakes. And we had a South African team that also went to go and help, as you can see on the side of this ambulance. We've also seen tsunamis, which followed earthquakes. We've also seen floods. We've also seen cyclones. So there's been a cyclone in the Bay of Bengal. But then also, even in closer to home, Malawi is a small country in Africa, and there was a cyclone Freddy, which lasted as long as a month. Can you imagine living in a cyclone for a month? And so this wonderful man, Imtiaz Suleiman, gift of the givers, has come and approached us and said, can we teach them about peritoneal dialysis for acute kidney injury? Because this is what they can use for people where you don't have electricity and you don't have clean water. And so this is just a graph that's happened over the many years, 1900 to 2020, droughts, floods, and earthquakes. You can see these numbers are big. You can also see what's happened, natural disasters from 1970 to 2022. So this is a real problem. If you don't believe climate change happens, maybe I've tried to persuade you by doing this. And so then to take you home, so I've been to Egypt. I'm now going to take you to Cape Town, which is where I live. And it really is a city of extremes. The good news is that the ISPD Congress is there in 2026, but also the Pediatric Nephrology Congress is there in 2025. So you can see beautiful city, lovely, expensive apartments, but in the middle of all of this is an informal settlement, and often running water is a big problem. And we lived through a drought in 2018. You can see this is the Theewaterskloof Dam, lovely green trees that supplies most of Cape Town City with water. And you can see in 2018, there was less than 10% water left in the dam. And if you've got less than 10%, you can't actually use that for drinking water. And so these memes came up, welcome to Cape Town. The feeling was that there was going to be a day zero round about April of 2021. Sorry, of the year of the 21st of April 2018. The World Wildlife Federation said it's time to prepare for day zero. And then we got from April to May of that year, and fortunately it then started raining. But you can see people queuing for water here, waiting for water from streams and little fountains that came off the mountain. And we were restricted to 50 liters of water a day. And I'm going to show you in light blue, that would be 18 liters for dishes and laundry. In darker blue, that would be 15 liters for a 90-second shower. And this is a picture of my shower with a bucket in it, because I would then collect the water that I use for showering, and I would then actually use that to flush a toilet, because one toilet flush consists of 9 liters of water. So that's a lot of water that you're using for every flush toilet. Daily hygiene for brushing your teeth. So if you run the water while you brush your teeth, you can easily waste water. 2 liters of water for cooking, 2 liters of drinking water for each individual person, and then also a liter of water for your dog. So you can see that 50 liters in a day doesn't go very far, and our politicians were pulling their hair out, but this was also what the management of our hospital was doing. So the question was, how do you run a hospital in the middle of a major city water crisis? And on one occasion, this is our pediatric dialysis unit, we were running out of water on our RO system. And so I had to actually take water from the fire hydrant and fill up our RO tank with that so that we could complete the dialysis session for these children. So it really was very difficult times. So what did we do then as a hospital? So this is an aerial view of our hospital. We actually identified 3 areas where we could maybe put a borehole. We tried 2 of the 3 had completely empty, no water, but the 3rd one we actually found what we called liquid gold. And so there we actually had water coming out of that pipe. And you can see we then set up proper tanks where we could collect the water, and we had water coming from the ground. The problem with that water was that it was very rich in iron, and so it actually stained our dialyzers quite quickly. We had very brown dialyzers, but at least we had some water which we could use until the drought had finished. And then moving on from a drought or lack of water to lack of electricity. So in South Africa, they call it load shedding as opposed to electricity outages. We've even got an app on our phone. It's called Eskom Se Push. And you can see when I checked recently, there was no power outages predicted. But this was a really big problem in terms of our children both on home ventilation, but also our children on home peritoneal dialysis. So we had quite a lot of children that we actually had on home PD. And so a few little jokes. This woman saying to her husband, "You've remembered Valentine's Day because of the candle, but actually it's just a power outage." And here you've got Father Christmas, who can't deliver his Christmas presents because he's looking with a torch to see where's South Africa because we've got no electricity. And this is our technical task team. You can see E.T. and the 3 blind mice and Dr. Zeus and even Mr. Bean trying to become a technical task team for our electricity supplier. And it really was a very difficult time. So this machine here, as most of you would know, is a home choice cycling machine that does dialysis. We use this in the hospital, but usually we have nice generators in the hospital. But if you're using this at home and the electricity goes out for 2.5 hours, this machine has only got a battery life of 2 hours. This is the Fresenius machine. This only has a battery life of 15 minutes, which is a big problem. And then again, this new machine is called the Claria. Many of you may know it already, and it's got a modem so that we can see when the patients go on and off dialysis. But this modem in itself is a problem because it also needs electricity, and you need Wi-Fi for that. The wonderful thing about using machines in ICU, especially the Clara, is it's now got the share source connectivity platform, so we can see what time the child went on to dialysis. Did they skip? You can see there's a red. Did they skip dialysis completely? So there's a lot that we can actually learn from that. And this is a picture of a young boy who lived on a farm, and it was a dairy farm, so they had cows, and the farmer had to make a decision between milking the cows using an electronic system or allowing this boy to use the electricity for his peritoneal dialysis. So that was indeed a really big problem. And fortunately, on this occasion, this was a picture of him coming with his dad, and he actually got a kidney transplant, which actually saved us having to have him on peritoneal dialysis for much longer. And then the other question that people always say, you may work in Cairo or I work in Cape Town. It's a very well organized center. But what happens if you've got a war on your doorstep and you actually have no access to dialysis? And I think there's so many wars going on around the world. I've just listed 5, but there are many, many more. And so that is a big problem for us. So interestingly, there's now a new theme of nephrology called renal failure in disasters. And so this was a paper that was published looking at what happens if you've got disasters. And in fact, if you've got a natural disaster, it may precipitate a kidney failure disaster as well, which is a real problem. And so what is a first aid kit for kidneys? Well, you can actually make up dialysis fluid using saline or Ringer's lactate and using dextrose with that to make up your dialysis fluid. And we also teach to use any plastic device, a nasogastric tube, a chest drain, a urinary catheter, to be a PD catheter and then save a life if somebody's sitting with anuria or a very high potassium. So you can say, well, everything I'm talking about will never happen to you. Well, during COVID, I was contacted one day by a group of doctors at King's College Hospital in London, where I'd worked before, a group of adult nephrologists who phoned and said, Mignon, we know you do a lot of dialysis. We are really stuck because all our KRT machines have been used up for COVID, and we are now sitting with children, with adults who really need dialysis. And so we had to teach them how to do acute PD because most people had forgotten to do that already. So this was Elaine Bowers, who's a fantastic nurse. She actually puts in the PD catheters and she trains her colleagues to do that. And so we're talking acute PD. We're not talking chronic. Chronic, I have a surgeon who puts it in laparoscopically. This is acute PD. This was for COVID-19 in a UK tertiary center. And the results of the study showed that 37 of 44 had successful catheter insertions, 5 not because the patients were so obese, but there was no cases of bladder injury, hemorrhage, or catheter-associated leaks, which is amazing. And so they managed to do RRT. They didn't stop because there was a problem with the PD. They stopped rather because the clinician wanted to stop. And so we said it's a safe and effective form of renal replacement therapy for severe AKI during a COVID pandemic. So for this talk, I'd asked people who could send me their favorite PD in AKI papers, and I got from quite a few of the doyens around the world. So Fred Finkelstein and Claudia Ronco, you'll all know well. And one of the papers was, are we biased against peritoneal dialysis? We then looked at this paper and it shows that it is an appropriate modality for dialysis in AKI. There's no difference in mortality, renal recovery rate, or infectious complications compared to extracorporeal treatments. However, more standardized reporting of trial design, technique, complications, and outcome is really needed. So a bit more studies are needed. We also then looked at the Thailand group. So Thailand really is very good at doing peritoneal dialysis, and they looked at lower dose acute PD versus acute intermittent hemodialysis. And again, there was no significant difference in the 28-day mortality between acute PD and hemodialysis. I was then very fortunate to write this paper with Brett Cullis and Fred Finkelstein, looking at development of PD in low-income countries as a rational solution for the management of AKI. And this study showed that it's more resource and environmentally efficient, especially in vulnerable populations such as women and children. The Saving Young Lives program, which I'm going to tell you about a little bit later, has demonstrated the benefit of PD for acute AKI. And then this is the same Thai group, also looked at barriers and constraints of acute PD and AKI. These are adults, and it showed that it happened in 58% of cases, limited to specific conditions. Only 9% of facilities performed PD routinely for AKI. And the major constraint was the fact that the medical team did not know how to put in a PD catheter. And so they feel that it's underutilized in Thailand and limited by inability to be able to put in PD catheters. And I think most of us who are more senior on this call would know that we were taught how to put in PD catheters while we were training, and I think that training has fallen away. So as part of Saving Young Lives, we are trying to teach people how to put in PD catheters both in adults and in kids. And this is a paper presented by Valerie Lux at the ERA, showing that more people are running water, less mosquitoes, more global births by skilled health personnel, more vaccine coverage. So there's more likely to progress to AKI prevention. And so hopefully that's something we should be aiming for. Nice paper out of Peru showed that they use AKI PD quite a lot, even in South America. They looked here at the number of nephrologists per unit. So some had as few as 5. We're talking adult nephrologists. Some had up to 11 to 15. And if you're looking at type of renal replacement therapy, they had PD or SLED or CRRT. And in those centers where you had many patients, people would be more likely to do SLED or CRRT. So all units reported performing intermittent hemodialysis. And it's good that there's research happening in this field, because this is a congress just on AKI from bench to bedside in May of next year. So I was recently asked to speak at the World ICU Congress in Mexico on innovations in pediatric renal management. And so prevention is better than cure is what I always feel. This is the children's hospital where I work in. It's really important to train people in teams. So this is a team of nurses. This is Jeff Burns, who's an intensivist. And he actually was standing there together with Brenda Morrow, who is based in our unit, but she's a physiotherapist, and she's the chair of the World ICU Congress. And here you can see nursing staff together with doctors. So we know in pediatric AKI, there have been a lot of developments in KRT, as Fatina said, even in the smallest neonate. But we know that many low and middle income countries have no access. And so we looked at our KRT at Red Cross. So here you've got 1,400 admissions to our intensive care unit a year. Our predicted mortality should be 10 to 12%, but we've actually got it down to 6 to 8%, and 3.5% of those are dialysis, but that's only a tip of the iceberg because a lot of the children have AKI. New technology, this is a child who was involved in a car accident, a 12-year-old. You can see he's got nitric oxide, a ventilator, all these infusions. He's got CRT, and he's even got a brains monitor. But what happens for neonates? So we're very lucky. We've got the Carpe Diem machine, which is a neonatal CVVH machine. We've also got the Fresenius machine. But if you do an audit, and this is the Carpe Diem, it's really an interesting little machine produced by Claudia Ronco. More recently, last year, for children, there was an acute kidney injury risk congress, which is happening. So people are more aware of this problem in children as well. And in pediatrics, they feel that there may be AKI phenotypes. So you can identify who's going to get severe and persistent and who's going to need KRT. So I think that's really exciting if we can actually predict Johnny is going to need dialysis, but Annie is going to sail through. So if we can work out which children are going to be in trouble. The problem with children is that at the moment, our therapy is only supportive after the AKI has occurred. If you think about it, it's independently associated with morbidity and mortality. And children, why is it important for children? Because they're going to live for a lot longer. And so they've got more time to develop sequelae like CKD and kidney failure. What are the high risk for kids? So these are the high-risk diagnoses: congenital heart malignancy, prem, and organ transplantation. What are the high-risk exposures? Infections, sepsis, nephrotoxins, and cardiopulmonary bypass. You know, in adults, you've got KDIGO. So we've got KDIGO for children as well, looking at your serum creatinine and your urine output. There's now also a neonatal AKI, so serum creatinine also and urine output, so it works the same. And for me, the most important thing when I teach is what is the percentage fluid overload after admission. So if you show that your child is more than, or even your adult is more than 20% fluid overloaded, they will probably need CRT. And this is a really easy formula. Thank you to Stuart Goldstein. Fluid in minus fluid out over your admission weight times 100, and that gives you your percentage fluid overload. So that's really important. And important before they come to hospital to make sure that you aren't giving them a lot of fluid. And he's shown this very eloquently: resuscitation, then all this time giving lots of extra fluid for maintenance and hemostasis, and then you spend all this time removing and recovering. Validated tools for AKI. I'm sure you might have heard about the renal angina index. So when you've got a cardiac problem, you've got angina, everybody runs. And in this way, they're saying maybe the kidneys should also have a renal angina index. And they've looked at many biomarkers. I'm not very impressed with many biomarkers, except maybe for the NGAL. And this is when you admit them to ICU, you do the renal angina index. If it's high over 8, and you do an NGAL, and that is high as well, you're going to go for a frusemide stress test and potentially for dialysis. If your renal angina index is low, you'll just go for standard therapy. And if your NGAL is low, you would continue with that. Whereas if your NGAL is very high, you would start with fluid restriction and then possibly renal replacement therapy. So quite a useful flow chart, I think, for people like us who work in low middle income countries. So then the important thing, I've told you there's all these new investigations and new equipment that's coming out, but what happens in the real world? And this is an interesting international pediatric dialysis survey. It was done in 2017, and it showed that in less well-resourced countries, there was only 30% CRT available, but PD was available in 100% of developing and developed countries, or less well-resourced and higher resource. So that's very useful for children, because if you've got PD, then you can really make a difference. And so this is work that comes out of Ghana. So Nathan Levine is from Fresenius originally. Samson Antwi is a pediatric nephrologist in Ghana. And so they are using expired dialyzers in here to be able to get clean water. And I would always say you must have conservative therapy, don't allow fluid overload, use a lot of frusemide, use aminophylline, and watch out for your nephrotoxic agents. So this is a very nice study done by Beatrice Nyan in our center, who's gone back to Ghana, and she's actually looked that aminophylline has a positive effect on the urine output in children. We would give 1 milligram per kilogram, 6 hourly, and with that, there was an increase of urine output on the aminophylline therapy. So that's something that's quite cheap and easily available. When is the best time to do PD? Well, the absolute indications are either a high potassium, severe acidosis, volume overload. Relative indications are listed here, but on the whole for us, for children, high potassium and high acidosis. You'll notice I've never put anywhere due to a high urea or a high creatinine. So somebody will phone me and say, I've got a child, their creatinine's 500, and I'll say, you know what, I don't dialyze for a high creatinine, but I would dialyze for a high potassium or severe acidosis. Moving on, what are the renal replacement therapy modalities? It depends what you're comfortable with. So for intermittent, there's these, but for continuous, I think PD is definitely an important role. And so we have PCRT. Iconic is a group of pediatric nephrologists who do some research together. And we looked at our dialysis program in Cape Town over 22 years. So it's a whole lifetime. And it's very interesting because this is a study that we did that was done by Cleto Yamani, who is in South America. And they looked at 13 years, 700 patients, but in a very large number of units, so something like 70 units. Their survival rate was not great. We then looked at our study, which is at Red Cross, so it's PD first for pediatric AKI, so we always go PD first. We looked at just under 500 cases. They were quite young. We used soft catheters, no rigid stick catheters, and these were inserted by the pediatricians in over 84%, so not by the surgeons, only 15%. And our survival for PD was not bad, considering the kids were actually very young and very small, less than 1 month. And these are in keeping with the AWARE and the AWAKEN studies, which have very similar outcomes. So what did we do? We looked at 600 kids. Median age is 9 months. Most of them, 57% were under 1 year, and almost 40% were under 5 kilograms. So these were the little guys. Causes of dialysis: cardiac failure, underlying kidney, sepsis and shock you can combine, and some oncology cases. And if you look at this, almost 80% got PD, but they were the younger kids, and then 20% got extracorporeal dialysis. They were the older kids, they needed a machine. So here's a picture of a baby who's got a PD catheter in the belly, and here's a picture of a baby who's gone to theatre for a hemo line, but also for a PD catheter. This was a child with an ammonia cycle defect, but it took us a long time to get this child to theatre. We probably waited about 5 or 6 hours. Is abdominal surgery a contraindication to PD? I'm going to ask you, and you'll probably say no. But if you can't get, this child was so swollen in the groins and in the neck, we could not get a hemoline in. And so we actually tried the PD with 2 catheters, one here and one here, and it actually worked very nicely. So just looking at our PD first, so we used Cook catheters in 60%, peel-away catheters in 26%, so these 2 together made up the majority, and only 8% of our patients needed to go to theatre for a surgically inserted PD catheter. So that's really important. Most of these catheters were put in at the bedside. Who put them in at the bedside? Well, either pediatric nephrologists and intensivists or nephrology fellows, which you may be familiar with, and then only the surgeons were needed in 15.9%. How long were these kids on dialysis for? On the whole, they were on dialysis for 72.6% of were on for 7 days or less. So not a long time. Most of these kids were on dialysis for a very short time. And most of the problems were blockage, poor drainage, leaking, and displacement of the PD catheter. 2 cases, we actually perforated the bladder, but that's because the urinary catheter was not inserted or it was actually blocked. So as I said, overall survival, for the bigger kids, they do a lot better than the little kids. And we offer PD or extracorporeal dialysis in our center. So we've demonstrated an acceptable survival in children with AKI. Outcomes are poor in small kids, but PD first in pediatric AKI programs with an acute start approach. So we don't wait for days or hours. We actually put in the PD catheter at the bedside, and then we start straight away, which seems to work quite well for us. So then I just want to talk a little bit about appropriate research for low middle income countries. And for those of you who know, this is Tim Bunchman. He's an American pediatric nephrologist, Stefano Picca, who's from Italy, and Pete Norse, who's in my center, quite an iconic picture. And we've been doing some work with Pete Norse on continuous flow PD. So 2 catheters. There haven't been many studies in peds. In adults, they're trying to do that. And so here's a PD catheter on the one side and a PD catheter on the other side. We used to use a cycling machine, but now we've moved more towards gravity assisted. So you can do this anyway. So you can see here's a gravity assisted device. 2 catheters, one there, and you're actually counting drops in and then drops out. So this can be done even in a war zone. It's really important to do that. Safety issues. We measure what the intra-abdominal pressure is using a bladder transducer, and we put the height of the delivery bag as low as possible. And we also watch the glucose measurement. And just to show you, look at the difference. Gravity assisted 25 mils or 50 mils. If you've got a single catheter, your clearance is not great. But if you've got a double catheter, your clearance goes from 0.6 to 1.9 and 1.3 to 4.54. So it's quite a big difference. And your urea and creatinine is also cleared really well with 2 catheters. So we're advising putting in continuous flow PD. So this allows for both improved solute clearance, gravity assisted, so it's low cost, technologically very light if you're in a war zone. Hyperammonemia, we can use it for as well. We use the multi-purpose Cook, and the only thing to be aware of is some albumin loss. And then just to tell you about our training. So we have trained 38 fellows from all over Africa in hands-on training. And this has been an amazing success. So just to show you, this is our co-authors. We've trained 44 fellows, of which 10 are South Africans, but the rest are from all over. And just to show you the map, so in blue are all the fellows that have actually gone back and set up peritoneal nephrology units in their areas. And that's really exciting. I feel like we've really made a big difference. And I know you guys do some training in Egypt as well. You do quite a lot in Cairo and Mansouri. And I think it's really exciting that we've been able to populate the African continent with people that have had training. So well done to you and all of your teams, Fatima. It's really great news. The only tricky part is that a lot of Africa speaks French, and so we haven't had many French training centers, but we're definitely looking at that, which is great news. So we did a survey on what happened when fellows went back, and mainly equipment and machines for adults, radiology by day, and surgeons were mainly adult trained. But what was not very common was pediatric PD, hemodialysis, consumables, often no PD machines, often no nuclear medicine, often no pediatric urology. So that's really serious. So this is a team, Adewale from Nigeria, Wally from Botswana, and Ethwaka from Malawi, who have recently spent 2 years with us. They've done training, they've done their exams, and they are now going back as some of the first pediatric nephrologists in their country. And what else did the trainees that we trained do with their skill? So this is a lovely picture that I took in September, 2-3 weeks ago. Bashir Admani working in Kenya, Francis Lalia working in Cotonou, and Samson Antwi working in Ghana. So these guys are now the new leaders of nephrology. They are on the IPNA Council, and they are leading the way and supporting me with the IPNA Congress. And then just in finishing, I just want to chat a little bit about Saving Young Lives. So this is an NGO, which is a partnership to deliver care for acute kidney injury. Just to point out, it used to just be young lives, but it's now definitely older lives as well. Somebody asked me the other day, what would be my cutoff? We said probably 90, although I have a neighbor who's 90. So 10-year-old anniversary of the Saving Young Lives. Who are we? A group from ISN, IPNA, SFNDT, the French group, and the Asian Pacific Society of Nephrology with International Society of PD, so ISPD. This is the steering committee. Brett Cullis is our current chair. And then these are our advisors and trainers. So you see people from all over the world who come and help us train. We do hands-on bedside teaching. And what started this? Well, initially in Mabingo, which is in Cameroon, they had no electricity, they didn't have HD, they didn't have much training, and so they started using locally made dialysis solution. They took Ringer's lactate and added some glucose to it. And do you know that the infection rate for commercial fluid was 16% and for homemade fluid was 16% as well? And so what we teach people is be very careful that you have really strict aseptic technique. Otherwise, you are going to give PD a bad reputation. If you want to know, this is the recipe for making fluid for dialysis. You can see you add different amounts of glucose depending on how much you want. We've tried this in newborn babies, small kids, and we only had a 4% peritonitis rate. So when people say the problem with PD is peritonitis, we don't see much. And in a similar way, if I were to ask you, if you were ventilated and you developed pneumonia, would you take that ventilated tube out? No, you wouldn't. And then why are we taking the PD catheter out if it's working well? So we had very low peritonitis in 49 kids, and Pepe Ukule in the DRC had a very similar number. So if you've fallen asleep because it's late in the evening and you've just woken up, because I've said, come on, wake up, these are the 2 guidelines that you really need to look at for acute kidney injury. They've got lots of recipes in them. They've got 2 guidelines. So for adults and for pediatrics, they are free and open access ISPD or Peritoneal Dialysis International. And that'll give you a lot of tips if you suddenly need to be doing dialysis for acute kidney injury in your unit, or you go to a war zone where you are asked to teach. So what we say is the gold standard: attempt to transfer the child to a pediatric renal center. Failing this, get a surgeon to place the tank off. If neither is possible, attempt bedside PD catheters with an ascites tap. The art of medicine, there's a whole lot of catheters that you can use: cannulas, nasogastric tube, chest drains. We quite like this adult central lines. Now we are teaching that. We don't like the rigid stick catheters because they can cause damage. Peel away tank off and the multi-purpose Cook catheter as well. But I know it's been difficult. So this is the initial PD catheter from Cook. We are now using multi-purpose, or in fact pigtails, which are actually very useful. And if you're a bigger child or an adult, you could use a peel away tank off. So that goes into that stylet. And then finally, this is a picture that somebody sent me from the Philippines. This is a baby who only had access to an adult central line. You can see the adult central line there, and we are recommending that people use this as a PD catheter in children. If you've got nothing else, your Ringer's lactate, your nasogastric tube over here, and your drainage bag with dextrose added to that. What else do we do? Manual dialysis. We heat the children, heat the bags by doing that. Is this low-tech medicine? I don't think so, because this is a baby with open heart surgery, oscillator, nitric oxide, a whole bunch of inotropes, but also a PD catheter or PD system. And you can see here the surgeon put in a Tinkoff, but often the ones the surgeons put in are very high. They don't go down to the pelvis. So in this case, we had to put in a little PD catheter closer to the pelvis so that the fluid could drain out of here and fill through that one. Three-way taps have really improvised and changed my practice in Africa, and bureau trolls to monitor how much fluid is going in as well. So what do we do at Red Cross? So we have a 5-day residential course where we teach Saving Young Lives in teams of people. So we teach them how to use pork bellies and put in a PD catheter. And I know at the Afran meeting in Egypt, they did a Saving Young Lives course using some pork bellies. If your patient needs resuscitation, we've taught them that. We teach them how to set up the dialysis. And this is a very interesting course. If you look all the different countries that we've trained people from, and we've had 190 doctors, 56 nurses, and 55 teams of people where we've taught them how to do hands-on PD. Samson Antwi, who was in the picture of one of my leaders, went back to Ghana and has actually taught over 100 medical officers how to set up PD at the bedside, and in doing so, playing it forward and saving a lot of lives. So what was the mean age? It was 9.5 years, mean duration 10.6, and survival to discharge is now much more. At the 10th anniversary, we had 500 patients with a 65% survival rate, but more recently we've moved on. So in the last 5 or 6 years, we've now trained 470 individuals from 45 different countries. And if I show you the map, you can see here's the map from all the places. In the beginning, we concentrated on Africa, and you can see there's the picture for Egypt, South America, and Asia. This was in Bhutan. When I got there, they actually had a real baby that needed dialysis, and so we had to use all our equipment instead of for teaching, for managing to put in a PD catheter into this baby, and this baby actually did very well. What happened during COVID? We then had a lot of virtual meetings, and important as well, if you want to see how we do tutorials, go on the ISN under Saving Young Lives resources and look at the video tutorials, and that'll teach you a lot about what we are teaching people. So ISPD Congress, the last one in 2022 in Singapore, and then we did some more in Bangkok. We've also tried to get more people trained in Southeast Asia and Oceania. We've also had an expansion across into the Philippines, Myanmar, and Mary Rose from that region has also been doing catheters herself. We also moved to Central and South America. Bill Schmoyer and Guillermo Hidalgo did some really good training and got a whole group of people together to do some hands-on training as teams of doctors and nurses. What's happened in Colombia, we've had the Teach the Teacher course, and then those people went out into rural Guatemala to go and save lives and teach people how to do dialysis. Even in India earlier this year, you can see Apane Yenga and the whole group. We were doing some teaching and training there. And then most recently in July, we did a course in Fiji, me teaching pediatrics, Brett teaching adults, and here Eddie Tan is an interventional radiologist teaching a student how to actually do acute PD on a pork belly. And you can see that we were training teams of people, doctors and nurses. The other important things about SYL is the advocacy. And so we got to meet the president of Fiji when we were there in July, and really important to be advocates and advancing kidney health care in the Pacific. And when we go places, we actually try and meet up with the Ministry of Health. So remember in Bhutan, I said there was a baby. Again in Fiji, there was a baby with sepsis and shock. They had a rigid stick catheter put in, and we then taught on the ward round how to manage a real baby with a good outcome. So Saving Young Lives, many activities in 2024, more coming up. We've just had an ISPD Congress. I'll show you that now. In India at the WCN, and also in IPNA, we're planning some workshops. How big are our workshops? Normally about 20 to 30 people, because we want to try and teach people in depth. And this was the ISPD Congress that Fatina was at as well, where we were actually teaching people using pork bellies how to do peritoneal dialysis. This is the whole group that joined us for teaching. And just to say that saving young lives really does make a big difference. So my take-home message for peritoneal dialysis for acute kidney injury, there's definitely still a role for this. We call it PD first because we always try PD first. For acute start PD, disasters prompts innovation and improvisation. So you may need to go back to basics such as PD, like we saw during COVID. I'm going to say watch out for climate change, because I think not having electricity, not having water is a big issue. And then my motto is that no patient with AKI should die without an attempt of a PD catheter, even if you use homemade fluids and improvised catheters. You need to make local solutions for local problems, and you can definitely make a difference wherever you are. And so I just want to thank my colleagues who are really doing a lot of fantastic work. Brett Cullis is the chair of the Saving Young Lives program. My two colleagues, Peter Norse, who came to Egypt instead of me at the AFRAN meeting, and Ashton Kutsia, who also works in our complex, as well as all our intensivists, and these are all our fellows. So to pay tribute to the trainees, both adults and peds, because they leave their families and they come to us for training for 2 years. That's pretty tough going. And then just to invite you finally to the IPNA Congress in February. We already have 730 registrations, so don't miss out. This is really going to be a fantastic Congress. And there's a whole day for adult colleagues as well. It's pediatric nephrology through the ages. And with that, I'm also going to say ISPD is the following year in Cape Town at the same convention center. So I just want to say thank you very much for asking me to speak. And I'm really hoping that that was a useful talk, and I'm available for questions.
Thank you so much, Mignon, for this highly comprehensive and elegant lecture. And I can see many questions on the chat, but before we can, Professor Fatina, please, can you comment?
Thank you very much, Mignon, for this very interesting, highly informative, and full of innovative ideas about acute PD and in AKI. Thank you very much. And I think we have to look for the questions.
Okay, so let's have a look-see. How long can an acute catheter stay in before starting PD? So remember, there's a big difference between acute and chronic. So chronic, we leave in for 2 weeks before we start. Acute, you want to start it straight away. So that's why I called it acute PD, acute start or urgent start. You don't want to leave an acute catheter in for a long time. You want to start straight away. And so the trick there is the same as you'd put in a neckline. You don't make an incision, because then you will bleed. In the same way, we don't make an incision to put in an acute PD catheter. We just push it through the skin with a needle. We do not use rigid stick catheters. We are now advocating to rather use adult central lines instead of those rigid stick catheters. So use a Seldinger technique. So I think that answers that one. Good question, yes. Mohammed. How do the two catheters work? One in and one out. They're not both open at the same time. We let the one that is running in run a bit slower than the one that's running out. So running out must be a bit faster. Otherwise, you're going to get an overexpansion of the abdomen, and that's quite dangerous. And so we also measure your intra-abdominal pressure through a bladder catheter. But we normally let it run out a little bit faster than running in. Were there any
the same measurements regarding intra-abdominal measurement, pressure measurement, the same applied for adults?
Same applies for adults, yeah.
Yes, okay.
So you can use the bladder as you can either use a tape measure like you would do for a CVP, or you can actually transduce the bladder catheter as well.
Okay, okay.
Very good question about were there any leakage problems from Fatima. So ideally, we don't want to use PD if you've had abdominal surgery, but in some children, they've been so small that we have not been able to do hemo, or we couldn't get any lines. So the smallest child that I've done hemo on was 1.7 kilograms, which is really tiny. But if you're really stuck and you can't get a hemo line in, it's worth trying with very low volumes to try and do PD even after you've had abdominal surgery. So I wouldn't say it's definitely out. Have we ever used a Nelaton or double lumen catheter? That's the one I showed you. I showed you that tiny baby who had the central venous line in. And then there's this myth about how long you leave it in. I don't know which university teaches you that you can only leave it in for 3 days or 5 days. I want to see the evidence for that. And if you get an infection, people want to take it out. So I'm going to suggest, what happens if you are intubated and ventilated and you develop pneumonia? Do you take your ET tube out, or do you rather just treat and wait for the infection to clear? And would you ever say that you can only leave an endotracheal tube in for 3 days and then you've got to stop ventilating? So why are we saying that for PD? I can't understand where that comes from. So those are very good questions. Multi-purpose drainage catheter, you kept it in situ for second 3-day cycle if you needed any problem. No, we run it every hour and a half. So we run in over 15 minutes, we let it dwell for an hour, and then we run it out over 15 or 20 minutes, and that works very nicely. Is it effective in severe hyperkalemia? So my record was a potassium of 13 in a neonate where we could not get a hemo lineup, and so that actually worked very quickly. Very short cycles, no more than half an hour cycle, so that you can change your fluid quite quickly. I think that's it.
That's it, no more. I have a question, please. My feelings that you speak about PD in acute settings, in severe acute settings. I want to ask you if you use PD at usual circumstances when you have normal choice for hemodialysis or CRRT or PD. Do you choose PD in these settings, or only leave for emergency situation, highly emergency situation when you cannot use hemodialysis or other extracorporeal modalities?
Those are very good questions. So in children, we use PD first, always, for acute and chronic.
Yes.
For chronic, it's great because we would then get a surgeon to put in a PD catheter laparoscopically. They would do an omentectomy and they would do a PECSI. And that catheter would then stay in for 2 weeks before we start using it. This is chronic, okay? This is not acute. And we would then wait for the 2 weeks, and then we actually send the children home on that cycling machine. I'm going to show you that cycling machine now again, just to remind you what it looks like. I'm just waiting for my screen to share. So I had that picture of a baby on a cycling machine. We do that at night because for children to come in 3 times a week, it's going to disrupt their schedule completely. And so we send children home on a machine that looks like, I'm just waiting to find it quickly. Just give me a minute.
Yes. Your time.
You've got your, I'm sure you've seen your cycling machines.
Yes, it was in the start of your talk.
Yeah, I'm getting there.
First 10 slides or something like this, 15 slides.
We actually are very lucky. All our children go home on a cycler. And the other problem with hemodialysis in children is that once you start putting in lines into the neck vessels or the groin is a problem because you are not going to, there we go. So there's our baby. That is the machine we send the children home on. If you start putting in hemo into the groins, then you actually mess up your femoral vessels that you need for transplantation. And if you put it in the neck, after a while, you're going to lose your access. So we've had children who've been on dialysis for 4 or 5 years. They go home, they sleep on this at night. In the morning, they disconnect, and they then go to school, which is amazing. And that's what we try and do. We do have hemo as backup, but we see hemo as a failure if we have to change from PD to hemo because you've got a fungal infection or because you've got peritoneal failure. So there seems to be a trend across the world that everybody goes to hemo, but you are going to run out of venous access for children. And to ask a 3-year-old, a 10-year-old, a 15-year-old to sit on hemodialysis for 4 hours, 3 times a week, they're never going to go to school. And one of their parents has to come and sit with them, so their parents have to give up their job. So I think it's very, very hard for their families. So that's, for me, a really important thing.
Okay, so you start first with PD in all circumstances in pediatrics. That's what I get.
We call it PD first.
PD first. Okay.
And now what we're saying from the paper that I've published is PD first, not just for chronic, but we're also saying PD first for acute.
Okay, question from Professor Ahmed Ala. Are you adjusting Claria machine on low flow dialysis, CCPD or tidal PD?
So we are using it for low flow. So we've got the low flow setting. So we can go to 5 kilogram baby. So that's 100 mils. Tidal we only use if children have got pain, but it actually works very well as well. And then somebody asked about a central line. So I'm going to show this picture again because the questions come up 3 times now. Can you use a central line for a PD catheter? And I'm saying the Cook catheters are extremely expensive. So we have now changed to teaching people about this. I saw there was a comment about some people using chest drains. We've definitely used that as well. But that is an adult central venous catheter. I don't know if you can recognize that. It's a size 8 adult CVP line. And it works brilliantly for PD because you've got an in port and you've got an out port. And so we measure that the PD catheter sits in the pelvis for the child. So it may stick out quite a bit, but you want to make sure that it goes in below the umbilicus and it sits in the pelvis, and then it actually works quite well. So it's not ideal, but if you've got nothing else, this is something that really works quite well.
Okay. Thank you for this.
See, there's quite a lot of other questions. So using Tinkoffs, yeah, I mean, I think there's no difference between silicone or polyurethane for peritoneal wrap, and that's why for Tinkoffs are for chronic PD. And that's why we get the surgeons to put them in, and they need to do it we get laparoscopic. And then if they do it laparoscopic, then they would actually put it in theater.
You don't use it for acute settings at all, Tango?
Because if you saw in our study, 85% of these are put in by the pediatricians or the pediatric nephrologists or the fellows at the bedside. To put in a Tinkoff for an acute, if you've got a surgeon, that's fine. But for us, we have 8 children's theaters in our hospital, and it could still take us 12, 24 hours to get the children to theater. Whereas with PD at the bedside, my record with one of my colleagues was 17 minutes from the time the child arrived on the bed to the time we started dialysis, which is pretty impressive.
Okay. Last question.
Nakhla has used a chest tube. Anything. Can we use a double lumen central line? So Zahid, that's exactly what this picture is.
Yes.
Okay, it's a double lumen. Can we use Ringer's lactate? So that's exactly what I showed you as well. Are we adjusting it? Yep. Can we use double lumen central line? So the same question again. Okay. PermCath, yes, we have used PermCaths as well. So any tubular device that actually works. And I think it's just important that people go and read those 2 papers. We made them open access. Okay. PDI, Peritoneal Dialysis International. You can use Brett Cullis as the main author. He's in both papers. My surname's a bit difficult, so you can use my name, but it's also difficult. But this is the update for adults and for kids. And in there are the recipes for making Ringer's lactate and dextrose. And so I'm not asking you to get rid of your surgeons, but I'm saying if you're in a situation where you don't have a surgeon or you can't get them to theatre quickly, don't let a child or an adult die without trying some dialysis. And you saw in Fiji, we taught lots of adults how to do PD as well. I think it's a dying art. I think people are very quick to jump onto hemodialysis machines. But if you're going to run out of electricity, or you're going to run out of water, or you've got a war zone or an earthquake, you're going to be in trouble if you don't know how to do PD. And so that we're just saying PD definitely still has a place.
Sure. So no more questions and no more comments. And Professor Fatina, can we close, please?
Yes, thank you very much, Mignon, for a very interesting topic and a very fruitful discussion. And I hope we will meet very soon again.
At the IPNA Congress, I hope so too. And thank you so much for inviting me to speak.
Thank
What a
you,
great
thank you.
audience at this time of life. Thank you, guys.
Thank you, Mignon.
Thank
Thank you,
you.
Mignon, for this very highly comprehensive lecture and for illustrations of all of your maneuvers you do in acute peritoneal dialysis settings. And thank you so much for your response to all the discussion and for this very interesting session. Thank you, and excuse me to close this session and meet you next Wednesday in the same time, 9:30 p.m. Cairo time. Thank you so much.
Thank you. Thank you, Professor.
Thank you very much.
Thank you very much.
Thank you. Bye-bye.
Bye-bye. Thanks, everyone.